Now, the immune system exists to fight infection, but also to fight cancer. And again, I won't walk you through this slide in its scientific detail, but what I want to say is that there are some head and neck cancers that have a biology that is amenable to using the immune system to attack it. And that's where the Keynote-48 study enters. So Keynote-48 was a study of the then new immunotherapy pembrolizumab, also known by its brand name as Keytruda. And the randomization here was the immune therapy alone, immune therapy plus the 2 standard chemotherapy drugs, or the then standard of care, the 2 chemotherapy drugs with cetuximab. The data set for this trial is rather complicated. I am not going to show it to you in its entirety, but rather simplify it down to what influences the patient-doctor team in the exam room for what the smartest thing to do is. I'm going to show you 3 groups of patients and 2 types of curves. So PD-L1 is a so-so biomarker that influences the probability of response to immune therapies. In head and neck cancer, high is a score of at least 20, which I'll show you first. And then we'll look at data for low, which is 1 to 19, and for negative, which is a PD-L1 of 0. And that's one way that we stratify patients biologically to decide what's most likely to help. The curves. Survival curve on the x-axis is time, and on the y-axis is percent of patients who are alive. Of course, if you follow any curve out long enough, we all die one day, but trials typically only go out a few years in showing you data. Everyone's alive at the beginning of the study, and of course, over time, people die. Progression-free survival, the x-axis is still time. The y-axis, though, to stay on the y-axis as a quote-unquote success, a patient has to both be alive and without growth of the cancer. And so it ticks down every time either cancer grows or a patient dies. It is less objective than survival because the measures of disease control on trial are very strict and sometimes overcall progression with immune therapy. So clear survival advantage, right? And that's our major measure. It's the most objective, and it's one of the 2 endpoints, the other being quality of life that we really care about. But it's an interesting shape to the curve. The chemotherapy with cetuximab as compared to immunotherapy are really just about the same through about 7 months. Immunotherapy does not act quickly. But in contrast, once you pass that point, you still have ongoing drop-off with chemo, but look at the immune therapy, it starts to level off. And in fact, in follow-ups to these curves, it stays pretty flat. And so immunotherapy offers for the first time the potential for durable control or even cure. It took me a lot of years, by the way, to finally use the C word here for immune therapy, but some of my first phase 1 patients with head and neck cancer are still alive and thriving with no evidence of cancer growth a decade later, and I'm finally ready to comfortably use it. Progression-free survival, we have that same, we have a nice crossover of the curves. So early on, chemotherapy plus cetuximab has better control of the cancer than immune therapy. Immune therapy takes time to kick in, but right around that 7-month point, these curves cross over and the immunotherapy looks better. And in the overall curve, there's a measure called hazard ratio that shows us that it's better. The other thing I want to point out is the relationship between these curves. Historically, in head and neck cancer, if a drug was a winner, if it worked, the advantage on the progression-free survival curve was always better than the advantage on the survival curve. And that happens because when cancer grows, you can give something else to help control it to keep the person alive. However, with immunotherapy, we undercall success on our trials. We sometimes call progression based on our messed up formal system called RECIST, and then the patient actually ends up thriving and doing great. And so our survival advantage is often bigger than our progression-free survival curve because some of these ticks down are not actually true, are actually people doing great. So in summary, if the PD-L1 is high, the better thing to do is monoimmunotherapy with pembrolizumab, otherwise known as Keytruda. And to boot, in addition to being more effective, it is less toxic by a lot.